Alrighty, welcome everybody. My name is Christina Vlahopoulos, and I'm a research project manager of Settler Creek Ancestry, joining you today from the Robinson-Huron Treaty Territory and the traditional lands of the Atikameksheng and Anishinaabe First Nation, also known as Sudbury. It's an honor and a privilege to have you joining us today as we present the findings from the first analysis together, learning from our ancestors, exploring First Nations mortality experiences in Northern Ontario. Before we continue with the introductions, I'm just going to take a minute with a few housekeeping items. This webinar is being recorded and will be posted on our YouTube channel in just a few days. If you would like to turn on the closed captioning, please go to the top of your screen and click on where it says more. If you're joining us by mobile, it could be on the top of your screen or on the bottom of your screen. And if you click on where it says more, the fifth option down should be language and speech. Under the language and speech, there should be an option that says turn on live captions. Once you turn it on, it may take a moment to engage, but then you should have closed captioning available for you. If you have any questions or comments, please use the question box that you can find again at the top of your screen with the other options. And finally, we'll do our best to answer any questions pertinent to the slide that we're speaking to, but most questions will be answered at the end of the presentation. So with that said, I will now turn it over to Maureen to introduce herself.
Thanks, Christina. Ani Maureen Nishnaka Shaganashi Mung, Gojujing Nishnakade Shkonigan. So I just shared my English name, which is Maureen. I'm from Koochiching First Nation, which is in Treaty 3 territory, and I grew up nearby in Fort Frances. I'm calling in today from Thunder Bay. And I'm the knowledge translation specialist for Mamo-Yamwin, which we will get into shortly. And I'll pass it off to whoever's next.
Rob, you're on mute.
This won't be good for the recording. Hi, everyone. Rob Gagnon from WAHA, the director of the Minimitaswim program. So there's the hilarious outtake for the presentation. Glad to be with everyone here today.
Thanks so much, Rob. And we also have Paul joining us.
Good morning. I'm the Director of Housing for Matawak First Nations based in Thunder Bay, Ontario.
Thanks so much, Paul. So today we are going to be looking at Mamo-Yamwin as an example of leadership in First Nations data sovereignty. We're going to highlight the variation in health outcomes experienced by First Nations across Northern Ontario. We're going to illustrate the importance of meaningful knowledge translation to support self-determination. And finally, we're going to talk about ways that Indigenous Services Canada specifically and other organizations more broadly can support ongoing First Nations health transformation and data sovereignty. So to achieve these objectives, we'll provide a bit of a background about Mamo-Yamwin, go over just a small number of indicators from the report, talk about impact and significance. We're going to go over some key asks and where we're going from here. So in 2016, 7 First Nations and health and social service organizations across Northern Ontario came together because of a shared challenge. They didn't have access to the high quality community specific data that they needed to make decisions and advocate for their people. So this group formed what was then called the First Nations Centre of Excellence in Epidemiology, or FINCE, and jointly applied for and received funding under Health Canada's Health Service Integration Fund, or HISA Fund. So this funding helped to provide and build the foundation for what would become known as Mamo-Yamwin. So Mamo-Yamwin, you might be asking, is a more fitting name for the group, as it means everyone's voices, or voices coming together. And it's a Cree and Oji Cree word to describe this. And the group felt that essentially epidemiology is like bringing collective voices together to provide a picture of health and well-being, and this name better describes what the group was trying to achieve. And so since 2016, Mamo-Yamwin has grown to include these 11 organizations that you can see on the slide. These organizations are a blend of health authorities and tribal councils and work together on common goals and interests. This alliance, it should be noted, is not a legal entity, and it's governed by a steering committee made up of 2 representatives from each of these organizations. And the steering committee uses consensus to make decisions, and they're generally the ones who guide the work. And so these 11 organizations on the previous slide serve these 78 communities across Northern Ontario, highlighted on this map. Communities span from the Ontario-Quebec border, the James-Hudson's Bay coast, all the way across the communities that border Manitoba. Mamayaman decided very early on that it wanted to be a Northern voice. And as such, the group decided they would only go as far south as the communities across the North Shore of Georgian Bay, or the communities between Sudbury and Sault Ste. Marie. And this is because the needs of the communities in the northern part of the province are unique compared to those in the southern part of the province. So as a really great example, most of the year, some of the communities are only accessible by plane, and or they have ice roads that are available to them in the winter. And if we take this map and overlay a map of Western Europe, as you can see on this slide, you can really get a better appreciation for the vastness of the geography. And while there may be some similarities across Northern Ontario, when you take a closer look at this map, you can see how the needs of the people with the communities vary. So as an example, a person in Italy wouldn't have the same health needs or access to health services as someone in the Netherlands or in France. So this image highlights that it's important that we do not paint all communities across Northern Ontario with the same brush and expect their needs to be identical. This is especially important for policymakers or decision makers who might not understand the vastness and challenges for those living in Northern First Nations. Things like access to healthcare, specialized services, the high cost of living, these and other factors are going to be different across all of the communities.
Thanks so much, Christina. So now that you know about why we came together, who's involved, and how our governance worked, you might be asking, well, what do you actually do? So we work with communities to find, analyze, and interpret data in response to questions that communities and organizations have prioritized, hopefully following a culturally respectful path. And we're going to break down what this means throughout the next couple slides. So the first thing we'll look at from that statement is the word data. Many of you will already know this, but we'll go through it just to make sure we're on the same page. And the word data is actually the plural form of the singular noun datum, which really just means a piece of information. So when we bring more than one piece of information together, it becomes data, plural, and we can use those pieces of information for reference or analysis. So in other words, we use them to better understand something that we might have questions about. As you'll all know, there are various types of data. We generally use administrative data, which is basically any form of personal information that was originally collected for a different purpose. So for us, this is usually health administrative data or data that was originally collected by the healthcare system. So every time we interact with the healthcare system, so you do something like going to the doctor, visiting the emergency room, getting a blood test, somebody records information about you in their system. So we use this health administrative data in the work we do because organizations and communities told us that they want to know and use what kind of data is already out there about us rather than collecting new data. So when organizations and communities have questions about the health of their people, we work with an organization called ICES, which was formerly known as the Institute for Clinical Evaluative Sciences, a bit of a mouthful, to figure out what kind of health administrative data is out there that relates back to their question. We then link this data from the healthcare system to data from the Indian Registry, which is maintained by the folks at Indigenous Services Canada. So many of you already know this. The Indian Register has personal and demographic information about all registered status Indians in Canada. So when these two databases are linked, or not always two, maybe more than two, but when that happens, any information that could be used to identify people, like their names or their health card numbers, those are removed. It's also important to note that the ability to link these data sets in between ICES and the Indian Register is always contingent upon approval from the appropriate bodies. particularly Chiefs of Ontario. We don't have time to go through the whole process today, but just know that they ensure that Indigenous data sovereignty principles are maintained and upheld. We can't just go and look at the data whenever we want to, nor would we want to do that. But anyways, once these data sets are linked, we can find people from our communities who are in both of those data sets to learn more about their health and to answer the questions that communities and organizations have brought forward. And I will hand it back to Christina to talk about the first project that we conducted using this kind of method.
Yeah, so now that we have identified members from Mamo-Yam communities, we're going to share a bit about the first analysis that we completed. And in the very early meetings of when they were coming together, the group identified many key priority areas. So some wanted to look at diabetes, some wanted to look at cancer, some wanted to look at chronic renal failure. And after many discussions, the group then decided that they wanted to take a look at the mortality experience of members from Mamo-Yam communities. And this topic was broad enough and sort of gave that high level overview, but at the same time touched on all of those key priority areas that were identified in those early meetings. So we looked at members from communities who passed away between 1992 and 2014. And at that time, we served 74 communities, so it's expanded to 78 as of today. And even though we serve 74 communities, only 59 communities chose to participate in the analysis. And this is because we only linked data about people from the communities that opted in and chose to participate in the analysis. All communities have the right to self-determination and decide for themselves whether they want to participate. And if they do, we need to have the appropriate approvals to do the work. Today, we're going to be drawing on from the findings from the overall Alliance level report and its companion report or comparative report. And this report essentially contains the information for those 59 communities that chose to participate. So when the time came for the group to have a first look at the data, we invited Elder Hammond Laxul from Laxul First Nation, and he shared this quote at that gathering. He said, "We don't see death as something to be avoided because we do not see death as the end of life. Sure, it is the end of our material life, but our spirit lives on with the Creator. Our time in the material world is temporary, and then we join our ancestors in the happy hunting grounds. Growing up, I was taught that when we see the northern lights, it is our ancestors dancing in the spirit world." And we always like to start off looking at this quote and reading this quote before actually looking into the data. It gives us a chance to really reflect on the people behind the data and to just ground ourselves in the work that and the data that we're about to see. We'll start by looking off at the overall mortality rates. Between 1992 and 2014, there were 5,685 deaths among Mamo-Yam community members, which is 1.5 times higher than Ontario overall. And when we look at the age standardized mortality rates for Mamo-Yam communities across all the communities, this is what this graph is going to show. But before we do, I'm just going to take a moment to orient ourselves to this graph. The y-axis is the rate per 1,000, and you'll notice that the x-axis says community number. Each community number responds to a random community, and this allows us to show the data while maintaining the anonymity for that community. And when we put in the data for the communities, we can see that there is quite the variation among the communities. Community 29, all the way on the left, is at a rate of about 140 per 1,000. And again, just as a reminder, this is the age standardized mortality rate. And then when we can look at community number 22, it's almost more than double. And finally, when we include the average age standardized mortality rate for all participating communities, that is the maroon bar that you'll notice that is in the center of this graph. So we do have a couple of graphs that are like this, and this is how the data itself will be presented. So now that we know about overall mortality, we'll look at premature mortality, or those who passed away before the age of 65. So about 61% of all deaths for members from Mamo-Yam communities were considered premature. And this is much higher than for Ontario overall, where only 22% of deaths were premature. And when we looked at amenable mortality rate, 3 out of every 10 deaths for members from Mamo-Yam communities could have been avoided with effective and timely health care or public health interventions. And finally, this is the premature mortality rate looking at all the communities. And again, you can see some variation from community number 35, which is a community that is on the far right, on the far left, all the way to community number 12, which is a community on the far right. And now I'll turn it back over to Maureen.
Thanks, Christina. Sorry, my mouse is a bit sticky right now, but Christina walked us through a bit of the data from the report, and I will continue that. So in addition to disaggregating the premature mortality data by community, which Christina just walked us through, we also did so by sex. So as you can see in the maroon bars, there was some variation by sex, with men from Mamo-Ayamoan communities being slightly more likely to die prematurely or before the age of 65 than women. However, when we add in the data for Ontario overall, we can see that rates for both men and women in Mamo-Ayamoan communities were still higher than the corresponding sex. So that's important to note and keep in mind. And while mortality rates give us really important information, it's also helpful to know why people are passing away to begin with. So here we have a graph with the most common causes of death for Mamo-Ayamoan communities. You can see at the very top that injuries were the most common cause of death, followed by circulatory conditions, other conditions, cancers, and so forth. But it can also be helpful to know how these rates compare to Ontario overall. So here you can see the yellow circles for the causes of death that were more common for Mamo-Ayamoan communities than for Ontario overall. So for example, even though diabetes is only the 5th most common cause of death in Mamo-Ayamoan communities, the rate's actually just over 4 times higher than for Ontario overall. This is important for us to know. While we don't always want to be looking at things from a deficit-based lens by comparing ourselves to non-Indigenous populations, this example does show how insightful these comparisons can be. And it's our partners and communities that tell us that this information is helpful for them, particularly when writing funding proposals or grants. It's not necessarily information we like to share publicly or always highlight in our public communications. But again, we follow the desires of the community in painting the narrative that they want to offer when we're talking about this type of data. I'll also just note that if you want to learn more about what is in each of these categories here, like for example, what would be part of the other category, you can go to the report on our website and you'll learn a lot more about that. So I'm sure you'll agree that looking at cause of death was insightful, but again, it still doesn't provide us with a complete picture of someone's health when they were passing away or shortly before they passed away. This is because of the cause of death recorded on someone's death certificate doesn't actually always tell us everything we might need to know. For example, if someone has diabetes and they develop an ulcer that becomes infected, their cause of death might be recorded as an infection, even though the infection was actually caused by that person's diabetes. So to help with this, we looked at the chronic conditions people had when they passed away, even if they weren't the cause of death specifically. So this graph shows how many chronic conditions people had when they passed away. As you can see here, we have 0 chronic conditions, 1 or 2, 3, and 4 or more, and each of those correspond with a proportion on the y-axis. I jumped a slide ahead, sorry. On the very far left, we can see that 12% of Mamo-Ayamoan community members had 0 chronic conditions when they died, and that was a lot more than for Ontario overall. Conversely, we see that 49% had 4 or more chronic conditions when they died, compared to 65% of Ontarians. So these two observations suggest that community members actually had fewer chronic diseases when they died compared to Ontario overall, which we found a bit confusing because it goes against some of the other findings we just learned about, where community members are experiencing more chronic disease and more negative health outcomes than the rest of the province. So when we looked at the findings with members of our steering committee, we determined that this was likely because Mamo-Ayamwan community members are dying so much younger, meaning that they don't actually get old enough to develop some of the chronic conditions that are common in older adults. So that was something that was really important to know, and also kind of highlights how important it is to look at that data with the people who are experts in their own lived realities, because that's not something that we would have known just looking at the data. That contextual piece is really, really important. And again, we don't get that unless we are working in a good way with community and listening to their lived expertise. We also looked at specific chronic conditions that people had when they died. So the conditions here are arranged from least to most common for Mamo-Ayamwan community members from left to right. So on the far left, you'll see that around 4% of community members had a history of rheumatoid arthritis when they died. This was the least common condition. And all the way on the far right, we see the most common conditions, which were diabetes and high blood pressure. Again, it can be helpful to understand how this compares to Ontario overall. So we added in yellow circles here to signify conditions that were present in a higher proportion of Mamo-Ayamwan community members who passed away compared to Ontario overall. So the conditions were kidney failure, history of substance use, mental illnesses excluding mood disorders like anxiety and depression, and diabetes. And again, you can go to the full report on our website for the breakdown of the Ontario numbers as compared to the Mamo-Ayamwan numbers, and just get a little bit more context. It's just really hard to fit all that data into one slide, so we're trying to focus on the really key pieces of information here. Again, as Christina talked about, we wanted to understand the variation within and between communities, because it's so easy to just paint all the communities with the same brush. There are lots of common challenges, but each community is unique, and we have to remember that. So we did disaggregate the data at the community level. So you see here, it's the proportion of people who passed away with a history of diabetes in each community. So we see a few communities on the very left have a relatively low percentage of people who died with a history of diabetes, while some of the communities, a lot on the right, had more than double the percentage, and that's quite a big difference. So again, the point we're trying to emphasize here is that there's lots of variation between communities. Often policymakers or funders, even with something like diabetes specifically, tend to take a one-size-fits-all approach across really big geographical areas. But these graphs, we really just want to emphasize that while we do experience shared challenges and histories, all communities do have unique needs and need to be treated as such. So these graphs and statistics, again, were just a sample of what's contained in the overall report. We do invite you to look at the full report, again, available on our website. And I'm sure if I looked at the chat, I would see that Christina has probably shared it in there. But we encourage you to read this in full to get more context on the methods, if that's something you're interested in, or on the data itself. But we do want to wrap up this section of the presentation with a few insights that we hope you'll keep in mind when you think back about what you learned today. Firstly, these numbers do paint somewhat of a grim picture, especially when we're talking about the comparisons to Ontario overall. But we really want to emphasize that well, we want to emphasize this metaphor that might help understand how we see this working. So there's a researcher who we work with. Her name is Dr. Jennifer Walker, and she shared this metaphor of this process being like a flashlight. So instead of shining a light just on the problem, she says that we're shining the light on the problem and then shining it forward to help understand what the path forward is, because we can't move forward unless we understand what we're dealing with. So that's really important to us because, again, we don't want to perpetuate deficit-based understandings of Indigenous health, but we do have to understand the reality of what's going on in order to understand how we can work with the strength of our communities to build a path forward. Another important insight to keep in mind when you're thinking back to today is that although numbers are really important, they're only one piece of the puzzle. And there are lots of other sources of information that we should value and be thinking about when we're trying to understand the health of communities. So this could include things like traditional teachings and knowledge, as well as people's lived expertise. We like to say that community members are the experts of their own realities. We are just giving the numbers to kind of give voice to what they're experiencing, but we shouldn't have to do that because we should be respectful rather of people's lived realities. Often that's not the case, so that's why we're here to do what we do, but we do invite you to reconsider some of those built-in understandings of which sources of information are more valuable or more valid than others. And we'll kind of continue to talk about that throughout the rest of the presentation because it is something that's really important. So if we're going to do our part, we just want to emphasize again, this is only one piece of the puzzle. It's not the be-all end-all. But it certainly does speak to many of the things that community members have told us that they experience. So it was really important for us to put a lot of time and effort into the knowledge sharing process, even after we finished these reports, because this is community's data. And if we're not sharing it in a way that's meaningful to them or a way that allows them to use it, there's no point in doing this work. So in terms of products or like physical, tangible things or virtual things, I guess, that actually communicate the numbers, we put together a few things. So as Christina mentioned earlier, we do have several different types of reports for this project. We have a report, the Maroon report, that's the entire alliance, so all communities in one report, and that's publicly available on our website. We also have the green reports. So those are the reports for each region or each organization. And then the blue reports are for specific communities. And again, we just want to emphasize that the green and the blue reports for regions and for communities, those are theirs to do what they want with. And we don't have the authority to share those. This is their data, and following First Nations or Indigenous data sovereignty principles, they are the decision makers and decide who they share that with. So some of them have opted to put them on their websites and others haven't. So that's something that's really important to us and we always like to emphasize. So in terms of reports, this option obviously caters to a certain audience. Not everyone's going to want to read a like 60-page report, which is very understandable. So this option was important for health directors and staff in organizations who needed lots of information to support their work. But we do know that even though they want all these numbers, that they are very busy. So we did try and keep the reports very visual, so they weren't having to read through pages and pages of really text-heavy content, because who has time for that? So in addition to these reports, we also put organizational and community level findings into slide decks and created one-page summary infographics. And finally, we created a whiteboard video that we've shared on our website and on social media for those folks who, again, aren't really interested in reading a very long report. This video was created to be engaging and accessible, and it uses a lot of plain language. So we want to make sure that everyone can understand what it is that we do, and that's really important to us. So we can't stop there because, as many of you know, it's not just enough to make something. It's not as simple as make it and they'll come, like everyone once thought in regard to research and knowledge translation. We also have to plan how we're going to share it with the audiences we want to reach and do this in a way that makes sense for them and their needs. So the first step was to share the findings back with organizations and communities, again, kind of prioritizing them, recognizing that this data belongs to them. And this is where those slide decks I mentioned came in. We shared these during interactive workshops and presentations, and by doing so, allowed people the opportunity to ask questions and talk about what the results mean to them. This in turn also enriched our understanding of those findings. So again, it's a mutually beneficial and reciprocal process. Some organizations also asked us to do press releases in order to help raise awareness about the health inequities that the analysis uncovered. Those were very powerful. We've also presented at academic conferences in order to reach researchers and the like. Similarly, we do have plans to publish in academic journals. Again, those aren't our primary audiences, but they are still important. Finally, we've also started to use social media to help raise awareness about our work with a wider audience and to make them aware that reports exist as resources for them and their work. It's also a great platform to share things like the infographics and the whiteboard video that I mentioned earlier. So we do have our social media handles at the last slide on the presentation if anyone wants to give us a follow. I have to say that because it's my job and I can't not kind of put that plug in. But yeah, it's an important tool for us. So getting into the impact and significance. Often we think about why does this all matter? I touched on this a little bit earlier. Hopefully you picked up bits and pieces of it throughout the presentation, but we will talk more about it now. So when data is collected, analyzed, interpreted, and shared in a good way, organizations and communities can use it to inform advocacy and decision-making, ultimately supporting their self-determination as a whole. And when we follow these processes, they're also more likely to actually make use of the data because all of this was being done to meet their needs. It wasn't like a secondary goal, it was the primary goal, which is unfortunately not always the norm in the research world. Of course, as mentioned earlier, it is only one piece of the puzzle alongside stories about people's lived experience, traditional knowledge and teachings, and other kinds of information that should all be considered when making the decisions about the health of communities. But again, this is what we as an alliance can contribute and what we're here to do. And in case you're curious to know more about what this looks like, we have conducted some evaluation to help us understand how the data is being used. And based on the findings, we know that organizations make use of the data in 3 broad or high-level kind of ways. The first is to support funding or grant applications. So we keep track of this, and we know that many of our organizations have applied and successfully received funding from a lot of different audiences or funders, I guess, ranging from private funders to provincial level funding to federal level funding. One thing we actually really commonly hear is that organizations use this data to bolster their Jordan's Principle applications. And we were shared a story by one of the staff at the organizations that one time they were writing a Jordan's Principle application and they included some of the data from this report in their application, but they actually forgot to include the report and attach it to their application. So when the person was looking over it, they reached out and said, where are these numbers coming from? You know, like we need to know. And the person said, oh, they were coming from this report. They shared the report and the person immediately said, okay, it's been approved. So that just kind of goes to show how powerful these numbers are. So the second category of how the data is used is to inform planning, from high-level strategic planning at the organizational level to concrete program level planning. So this is really important. We've also heard from some organizations that it's even been used in Ontario Health Team planning and the like. So it is a really, really important resource in that sense. And thirdly, we have this category that's kind of a catch-all for some of the unique ways that specific organizations have used the data in their day-to-day. So as an example, one organization did tell us that they've used data from the mortality analysis in their orientation for new staff, volunteers, and board members, which we thought was fantastic and a really cool way to make use of this data. So now we're going to invite Paul and Rob, who we introduced earlier, to share a little bit about how they've used the data in their day-to-day work. They have a little bit more time, I think, than they planned. So yeah, please feel free to take it away, Rob, and no need to rush because we want to hear from you and learn about the important day-to-day work that goes on and how the data kind of plays into that. So I will hand it off to Rob.
Thanks, Maureen. So yeah, so I'm here obviously on behalf of Winnebago Area Health Authority. Pleased to be here. Pleased that everyone could join us. Just wanted to talk a little bit about our organization and certainly where it's situated and provide some other information that way for you all. So we basically, as the Winnebago Area Health Authority, provide healthcare services to people living along the eastern James Bay and Hudson Bay coasts. So in terms of where our regional hospital is located, Winnebago General Hospital. That's situated at the southern tip of James Bay and Moose Factory. So in addition to that, we also have a number of other facets to us that I will discuss in future slides. Next slide, please. Perfect. So just taking a closer look at the region and some of the historical context and bits of information that are related. The meaning of Winnebago is actually the meaning of its two bays. And it's also a Cree name that refer to the waterways that make up the traditional territory as Winnebago. The majority of the people living in the region's coastal communities and just overall in the Waha region are Cree, 90% plus, in fact. And then for Waha, we have hospitals located in Attawapiskat, Fort Albany, and our regional hospital, which is based in Moose Factory. We also provide supports to our ISK partner federal nursing stations in Saskatchewan and Pewanak, and Waha also has a health center in Moosonee. So in addition to what I've mentioned, I mean, we're a gambit of services that are quite unique for the offerings that we have. We provide in and outpatient services, depending on the types of sites that we have. So things like obviously emergency departments, family medicine clinics where people can do doctor's appointments or NP engagements. We have a dental program, which is kind of wild. Dentists and dental hygienists that provide service to the bottom and top of the region. A diabetes health education and prevention program. A mental health and addictions program, which provides service everything top to the bottom of the region. Rehabilitation services through PT and an OT. NHB, medical travel support. So we actually host that through Waha too, which is kind of wild. Diagnostic imaging services. We even have ambulance bases in every community with a first responder service in Pewanak. And the lists honestly go on and on. So we're quite unique. We're quite diverse in our service offerings. And really our mandate is to provide optimum health care to people in our region as close to home as possible. In terms of some of the history of what Waha is and how it came to be, Waha was established in 2010 after the integration of the provincial James Bay General Hospital and the federal Winnebago Health Etoskawin board basically into becoming Waha. So there was kind of like a progression from the hospitals that were transferring basically from a federal format over to provincial. So it's quite unique. And our history is really interesting. So how it all started was Moose Factory General Hospital was originally constructed in 1949, opened in 1950 as a TB facility. So it's basically a 200-bed TB sanatorium of sorts, treating patients from as far away as the Northwest Territories and providing hospital services to the east and west coasts of the James and Hudson Bays. Over the years, treatment of TB changed, and hospitals as such decided this, maybe wasn't the main focus of what the hospital and Moose Factory should be and the range of services in the region should be. So by 1966, the name of the Moose Factory General Hospital was changed to the Moose Factory General Hospital. It became the regional facility providing hospital services to the communities of the Western James Bay. And then in 1996, our services transferred from the federal government under Health Canada to a locally appointed and controlled board of directors under Winnebago Health Etoskawin. It remained funded by Health Canada with some provincial funding. And it's important to note within that history as well, into the 80s and 90s, we opened, the health center in Moosonee, hospital in Attawapiskat, hospital in Fort Albany, and then the ISK nursing stations in Cache and Pewanak remained as they were. So again, we have quite an interesting history and diverse sites. We meet diverse needs of people within the region, and I think we're a really neat health authority. So next slide, Maureen. So now we're going to look at the program that I'm the director of. So the Minamitasawin Healthy Living Public Health Department for Waha. So basically, what we are is a community developed and led public health model and approach. We support public health analysis and commitment towards meeting the needs of communities by identifying public health priorities and data needs overall. So we have continual engagement with our health directors in each community to identify needs and provide support. And we assist with community-driven research questions and participation. So we've done things like wastewater surveillance. We've even had a request from a community around looking at the incidence and possible prevalence of lupus. And we have other things that have been we've been approached by WAHA by external researchers to look into to help the region acquire data in areas that we desperately need that data for, which is also why we're part of Mamo-Yamwin, by the way. The challenge we've always had previous, and this has become less and less over time, with very little region-specific health data, it makes it hard for leaders to plan impactful community health programs. So what we've done is we explored options for creating and sustaining partnerships with several organizations, including Mamo-Yamwin, in order to provide our health leaders with the data they need. So it's a pretty whole and holistic approach, which we're very proud of. There's more services we're also going to be offering within Minamitasawin in the near future. A lot of programming in alignment with the data around injury prevention and promotion, certainly chronic disease prevention and promotion, leveraging what we've seen in the data, mental health and substance abuse prevention and promotion. These are all things that have been known to be emerging priorities, but that the Mamo-Yamwin report really drew out more strongly for us. So next slide, please. So now, looking at the different levels of reports we have up on our screen, the Waha region green-based report, which we've distributed quite well since we had it available in 2019, and then the companion report. So basically, our collaboration between Minamitasawin and Mamo-Yamwin utilizes a community-driven, strengths-based approach. As Maureen mentioned, sometimes we focus too much on deficit-based approaches, and we'd rather sometimes look at strengths-based approaches. Despite the data kind of painting a grim picture, we remain very optimistic within WAHA, and I think it can speak for a lot of partners in saying that the advancements they're making really a number of strengths that we could describe in the various offerings we have. So again, our overarching goal is translating data into meaningful information for communities in response to their questions and ongoing living initiatives that complement the work we're already doing, which I think I've talked about a little bit. And we've used the findings in many ways. So when you look at it at a high level, it's been informing future research and bolstering funding applications for us. I'm even just looking at the side here on some of the things we've used it for. We just got funded for a fairly substantial amount of money for a significant regional harm reduction program. Dr. Lockman and the Mount Sinai mental health and psychiatry team comes up on a monthly basis to support our patient needs. We also had a preventative care proposal that we just put in that we're going to be getting a preventative care specialist to help coordinate and help people navigate the broad range of services that we have. We've also used it to bolster our diabetes department with the offerings there. And the list grows and grows and grows. I feel like every month I find out about a new WAHA department initiative program that's been impacted by the strength of the WAHA report and also the overall partnership report. So just to really show people the value of what it means to be part of Mamo-Yamwin, for us, it's been significant here at WAHA. So again, just flipping to the next slide. We often, again, as mentioned, use the findings to bolster our funding proposals, including those for mental health and nursing services, both of which were successful. So nursing services is another one I should have mentioned. We also incorporated those findings into a Waha COVID-19 CIHR grant with Queen's University, once again speaking to the importance of partnerships. We also used it to help with the UHN project for remote heart monitoring, which has become a big thing in our region, to allow for onboarding of patients that are at various stages of heart failure to try and catch people earlier in the continuum as we go forward, but also support those that unfortunately have a little bit more advanced heart failure situations. And in closing, from my end, the data such as that provided by Mamayamun is beyond the value that I could even describe. It provides important information to our healthcare providers, organizations, communities, and external partners to better understand the needs of the patients we serve. So I hope that's been a good account of what the value is for Mamayamu and Waha. The program means so much to us, and Waha wants to thank all the ISC attendees and everyone involved for taking part in this and for listening to me talk. I'll pass it back over now to our presentation team. Thank you very much.
Thank you so much, Rob. Again, just such a good analysis of how impactful the data has been. And to kind of further that, we're going to invite Paul up to speak about how the data has been used at Matawa First Nations.
Hello, as I said earlier, my name is Paul McGiskin, the Director of Housing from Matawa First Nations in Thunder Bay, Ontario. And I've been given the task of the answer of being asked, how do you focus on your mental health when you don't know where you're going to live tonight? And something that we see a lot is just a complete connection and overlap of supports required to actually help somebody. So a quick overview on Matawa. We offer a slew of programs starting through with education for youth and adults, including employment training. We have social services supports, including the navigating child welfare matters. We have healthcare in both our clinics in urban sites and in our communities, as well as mental health teams that provide supports in both areas. We have the nonprofit housing, which offers deeply affordable rental units here and in communities. The emergency sheltering units here in town, transitional units for post-majority care, technical supports for community development, both here and into their respective communities. With that being said, Matawa communities represent about 75% of the population recently identified in a PIT study who identify as homeless or at the risk of homelessness in the region. So as one thing we try to do is the constant expansion of our services, something that we've now hit a breaking point, which I'm sure many of you have seen in data reporting requirements. I understand the pain and the frustration that some of you may have with dealing with certain agencies providing anecdotal information that, while paints a dark picture of services, doesn't always equal service expansion. And for us to build that capacity within each community would in and of itself provide a complete generational gap before services could be accessed, or we could look at our own expansions instead of utilizing Mama Amawayan. So having this is every one of our communities and every one of the other communities that we've interacted with, data governance is a massive issue right now, but it's also a massive hurdle that we need to overcome in the service delivery area to actually be able to say, here is our demographic, here is our scope of service, and here is an actual data reporting requirement that meets the funder's needs. And in today's world, there's only about 2 projects left that are completely funded through one sole funder. So navigating in between them, finding out which works best is becoming increasingly more difficult when we would hope that it's becoming a little easier. And one of the things Mama helps us show is how is data or not, how is money being utilized currently by finding out exact data points. Where are people accessing services? Why are people not reporting things? There are communities who don't report certain health issues, and this is just directly through our communities, who don't like reporting certain illnesses or even utilizing certain health services that are attached to child welfare agencies. And it's just unique issues like that force us to say, how can we connect this data to service delivery because almost every service delivery, when it deals with the chronically homeless, is going to be complex needs. It's going to touch on almost every area. And how can we help somebody navigate through that while also showing a lot of the hidden costs? When somebody from ISK, for example, pays for somebody to come from the community to access emergency health care in an urban setting, there's also the additional costs of having somebody travel with them. But then there's also the fact that some of our elderly who are most at risk of falling to chronic illnesses are struggling with the idea of that they are now the primary caregiver for their home. Can they provide suitable child support for their time to go and address their actual health? Or would the health requirement be that they no longer live in the community, something that they're not willing to give up, and something that we face constantly? How can we show this is how much is being spent by this individual, and how can we work with the communities to show that data in a respectful and a good way that says, here is how you're being represented, and here's how your data is being collected, stored, and shared. And it's not something every community wants to be a part of. As you've seen, many of the communities just don't want to take part in certain surveys and number keeping. They don't want to be identified as just a number. And there are, on the flip side, we understand that the funding is modeled after data reporting requirements. And I'm sure many of you have seen certain reports that said, we have X and Y amount of dollars going into this community, but we are still getting constant requests, or why is this issue still existing? And it usually comes to a complete waterfall of, yes, they're getting this much money, but this much is being lost to this. Or we can't actually build a dialysis unit in that community because they don't actually have access to clean enough water to do that. That's requiring those individuals to constantly leave the community and build up those traveling costs. I know the amount of ISK dollars spent on just traveling from Thunder Bay to the communities for care is astronomical when you would compare it to the cost of actually developing. But we do have to be respectful of actual capacity within the communities and to making sure that what works and what's realistic is there, and without actually having data to go through and to prove and to actually work with someone like Mama Wayne to say, here is some actual data to represent your community. How can we share it? How can we better utilize it? And that helps us in building better funding agreements and better requests. Not all of our requests come out 100%. We might come back and say, we missed this and we missed that. We're asking for it to be added on, or we're simply asking for one line item to move to be somewhere else, as we've had overages or expenditures that didn't quite get fully realized. Staffing capacity is a massive issue. And just that knowledge translation of what is happening there and what is required by major funders to say, here's that middle ground. We absolutely and cannot move forward without agreements in place with an agency like Mama Amaway, and that can help push us to say and show us a better way of representing ourselves. We have very unique needs, but Mama Amaway is the keystone to translating our needs into data. And I don't know if it sounds cold or not, but that is a requirement to move forward. And I'm sure going forward, it'll get a little bit easier. But for now, there is no way we could ever rebuild the capacity that Mau Mau provides to our communities in each community, or even here in a centralized location. We need this support to go forward. And as we build on more complex funding agreements, we need to better reflect data reporting requirements for everyone. So we're just trying to identify and realize that, yes, we are getting significant funding, but sometimes we need to better utilize the funding that's coming in and better identify how partners can kind of see this through to the end. I don't want to ramble too much. Thank you.
That's great. Miigwech, thank you so much, Paul. I think both you and Rob did a great job of, in a very short amount of time, highlighting the complexity of healthcare in your respective regions, and how the data hopefully helps support folks in your organizations to navigate that complexity. So Miigwech, again, thank you so much. And now that we've taken a look at that, I'm going to pass it over to Christina to talk about some of the key asks. So now that you know some of the challenges, and hopefully that now that we've highlighted the value of this work, we're going to talk about ways that hopefully the folks on this call can help support us in our work. So over to you, Christina.
Thanks so much, Maureen. So yeah, I think it's safe to say that Paul and Rob and what they share today just really scratches the surface in terms of ways that this data has made a difference for them. And I also think it's safe to say that the steering committee, they are the big data champions in terms of understanding the need and the desire to access this kind of data to support them in their initiatives. And so even though this data provides the numbers needed, there's always room for more. So the last objective today was to talk about ways that ISK can support ongoing First Nations health transformation and data sovereignty. And again, I mentioned ISK specifically, but this obviously goes beyond Indigenous Services Canada. And while we realize that on the call today, we may not have a lot of key decision makers, but we know that many of you either work with, report to, or somehow connected to some of those key decision makers. And we think that the more that we can share this information and some of the key asks from the steering committee, the greater the potential for this information to get to those decision makers to create long-lasting, transformative systems change in First Nations public health. And I think all too often, decision makers tend to lean on Band-Aid approaches or one-off programs that they'll provide the funding for. And unfortunately, these approaches are not going to provide the long-term changes that are needed for regions and communities to achieve health equity. So approaches for that change must come from the First Nations themselves. They already know what is happening in their communities, what gaps exist, and how best to serve their communities to fill those gaps. And you can see just listening to Rob and Paul today and how varied there are some similarities, but also the differences between the two organizations. So there are a number of ways that decision makers can support efforts. For instance, Paul already touched on this one, and that is providing funding that is more flexible. The graphs today that we presented that showed the communities across the screen on the slide, you could see how each community is unique. And sometimes when it comes to a blanket approach to funding, it's not necessarily going to work. For some communities, less funding is needed because they have other programs or services that is managing that condition, or it's like, say, for instance, if it's diabetes, they already have programs for diabetes that is so far successful in their community. So they don't necessarily need more funding. But for other communities, their rates could be much higher, and what they have isn't necessarily enough. So flexible funding not only allows a community to fill those gaps, it's that the gaps that the community itself has identified, but it also supports a community's self-determination. Other ways that decision makers can support First Nations is through ongoing investments in operational funding and an entire EMR or electronic medical record systems. So it's not just about having access to EMR systems itself, because that's just a part, as Maureen was using the puzzle analogy, that's just a part of the puzzle. It's about having the infrastructure in place, things like actual computers or laptops, network servers, internet, and even facilities to work out of. And in some cases, we heard recently about how one community lost power. So even having a backup generators for power to be able to provide power to the computers and the laptops. It's not enough to have computers there. You also need to have the people in place to support that structure. People who are specialists in IT, people who are EMR champions to help with the switching over to an EMR system, because in some cases, some communities are still using paper-based record keeping. There's also a need for people who have data literacy skills, and it's important to provide some of those training opportunities for those who might need that support. Finally, decision makers can support First Nations by facilitating access to data about First Nations. First Nations have an inherent right to available data collected about them. This was identified both in the United Nations Declaration on the Rights of Indigenous Peoples, as well as the First Nations principles of ownership, control, access, and possession. If there's a way to support First Nations inherent rights to that data, it supports a path to data sovereignty. Now that we've completed the first analysis looking at the mortality experience, then the question becomes, where do we go from here? We had an opportunity to examine the preliminary findings back in January of 2019 for the mortality analysis specifically. The steering committee who was available at that meeting, they identified 3 key areas where they wanted to take a deeper dive and look a little bit more closely into the data. As mentioned before, the mortality analysis sort of provided that high-level overview, and now the steering committee, after seeing that data, identified 3 key areas, which are chronic conditions, mental health and addictions, and injuries. So far, we've outlined exactly what we want to learn and what we can learn with the data that we have available to us, working again with ICES on these projects. We've completed the community opt-in process, and we have 70 out of 78 communities choosing to participate, which is really great and just really highlights that communities are also understanding the importance of data and understanding the role that Mamayaman can play in terms of helping to support them to access this data. We've also reached out to people who are experts in these areas being chronic conditions, mental health and addictions, and injuries, to help us support the work and ensure that we are looking at the indicators in a good way. And to date, we've also held 2 ceremonies to honor the people behind the data and to help us start the analysis in a good way. This year is going to be a good year for us because we hope to get some of the initial findings back to the regions and communities through co-interpretation sessions. And of course, this will then lead to reports and presentations and other knowledge sharing products to share the results. And in some cases, we have had opportunities to connect with the organizations, and they've shared ways that they think that will work to the best ways that will help them to share the information with the community. So leaning on them, again, looking at them to their expertise for that knowledge sharing piece. And we're really quite excited to see where this year is going to take us. COVID certainly kind of slowed things down for a little bit, but we're right back at it. And this year is going to be an exciting year for all of us. So before we get to the questions, I just wanted to acknowledge that we do have a number of steering committee members joining us today. And I know that we have the webinar such that people's microphones and cameras are muted and turned off. But if there are any steering committee members who would like to share anything or say anything, because we do have some time, to please just write a message in the chat box, and I'll be sure to make it so that way your camera can turn on and your microphone can turn on. And while we're waiting to see also for any questions that come in the chat box, I just also wanted to give special acknowledgement to 2 other members who are on the call today who are part of the Mamayaman team. We have Yantao Zhao, who is our senior data analyst, and we have Beth Rakulis, who is a staff scientist who works at ICES. So just a special acknowledgement for them as well. And so Maureen has on the slide ways that you can get in touch with us. Feel free to email us. There is our website, which was also posted in the chat box earlier on. And of course, we do have our socials, as Maureen mentioned, through Facebook and YouTube. And you're more than welcome to get in touch with us that way too. So that concludes the formal part of our presentation. And I see that Paul has his hand raised. So I'm going to ask Maureen to turn her camera off while I try to make it so that way people can enable their camera and their video. So Paul, I've enabled, I gave you permissions to be able to turn your camera on and unmute yourself, so please feel free. And again, in the meantime, please feel free to put questions in the chat box.
Oh, thank you.
Yeah.
Just wanted to mention thank you to everyone. Thank you to my colleague, Paul McGiskin, and others, and that have done this work, and certainly to everyone involved. one of the things just wanted to mention is the flexibility and the adaptability of the data. One of the things that we're seeing is, and I think Indigenous Services Canada is seeing communities across Ontario, and I'll be honest, it has been certainly identified by our communities, is that they are being confronted by issues of massive drug abuse and issues with drug policing and other things. And I think one of the abilities that we have is the ability to pivot and use this information to address some of those issues, but in connection with the policing and justice sector and some of the housing and some of the social supports that kind of lead people on a tangible way out of some of the statistics that we're finding. So I think that this whole initiative, as we move into broader issues of community safety and well-being with other partners in the justice system, in the housing system, and support services, I think all of that will play a role and hopefully help people live better lives. So, Gwetch.
Miigwech, thanks so much, Paul, for your insights. And one thing that we didn't mention in the presentation is that the goal for Mamayaman as a whole is to achieve health equity, for communities to be able to achieve health equity. So thanks so much for that, Paul. And I'm just keeping an eye on the chat box. I don't notice any specific questions in the chat box yet, but I do see a hand. So what I will do then, if you'll just bear with me. So Hasib, I see that you have your hand up. I can allow your microphone if you wanted to ask your question. I'm guessing you have a question.
Yeah, thank you so much.
Yeah, go ahead.
So can you hear me? Yeah, Christine?
Yep.
Yeah. Congrats from the bottom of my heart. It's a great work and it's a great data. So I'm finding out, a few things. As per there is UN, as you mentioned, UN released a report that they measured, development index. What is that? It's a composite score of life expectancy and health status, education status, and living standard. If, based on that, report, Canada is among top 10 countries. But if we, include Indigenous, data, Canada would be ranking, 55 to 65. That report is released in 2016. So it shows, how, disparity, inequities prevail. I would encourage, in addition to collecting, quant data, qualitative data would be, very much, helping us, giving us meaning in perspective and in depth. Now, when it comes, to community empowerment, we have to use, this data to empower our communities. It could be in terms of informing, consulting, advising, and engagement. There is a cycle. And we know that there is a cycle to data, information, intelligence, and wisdom. And if we, use the data to its full capacity, we could reach, that wisdom to influence policies and also address, inequity. Inequity is, working to reduce inequality. And through even when we, gather data and analyze the data, we see that over the years, the gap is widened in the Indigenous and First Nation communities. So thank you so much. And there is a lot of scope, to use this data to influence, policies, programs, and improve the health outcome of Indigenous and First Nation communities. Thank you so much.
Thanks so much, Hasib. Thanks for your insights. And I see Maureen, you also have your hand up. Please go ahead.
Yeah, I noticed that there aren't a lot of questions or any questions yet in the chat box. So I thought I might ask, maybe we can expand on why we chose 65 as the cutoff for premature mortality as opposed to 75, which is what's used in like departments like StatsCan. If there are any folks here from that organization, I think we may have really briefly mentioned this during the call, but since we have time, maybe we can expand on that a little bit. And I was going to ask you to do it, but I don't want to put you on the spot. I can also talk about it. So
for sure. Yeah, for sure. Yeah, that I think that is something that was really important. And again, we also want to be mindful of the time during the presentation. But there was a reason why. And if you notice, when we did talk about premature mortality, we specifically said 65. And that's because when we first started to look at the data with the team, we actually had to move. Initially the cutoff was 75. And we noticed that 75 was actually too high of an age as a cutoff age for premature mortality. So we chose to move the premature mortality rate to 65. And so that was actually by design. And it was necessary in order for us to be able to do the work and reflect what some of the data was actually showing. Yeah, thanks, Maureen, for that great question. And so I also don't see any other questions, but I do again notice that there are a couple of other steering committee members who are on the call. So if any other steering committee member would like to share, and or if Rob or Paul, if there's anything that you wanted to share above and beyond from your presentation that you didn't get a chance to talk about, please feel free to turn your camera on and unmute yourself. Yeah, go ahead, Rob.
Thanks. I think like the impetus for this alliance at the very start, when it roughly a decade ago, when the idea was had around it, was, you know, kind of combining the Northwest and Northeast to see, you know, again, what our data needs were, and knowing that our populations were each small, how could we come together to work on, you know, common data initiatives that would provide maximum benefit to our communities, our regions, and to inform our health planning priorities and a number and a gambit of different things that we talked about in this presentation. So I really want to highlight the importance of that, because that really is, I think, for me anyway, foundational. The Mammo Yamwin is kind of almost a strength in numbers approach, where us coming together, we certainly have our own community, regional / organizational, and the overarching partnership level reporting being done. All that to say that at various levels, we're gaining a greater understanding of what life expectancy and Indigenous health experiences are in the Northwest and Northeast, and that's so paramount. It's been a game changer for our organization, and as our organization continues to have the people that we have that have been working for here a while and new people, the ones that have come into contact with this, and we do as much outreach as we can to make sure people are aware of the report, everyone agrees by consensus that it's massively been beneficial in a number of areas above and beyond even what I know. So I have to recanvass people on a continuous basis to see how this report is being used. And like I said, I learn every month or every second month that it's used by another department for something significant to enhance or have a service exist that never did. So just wanted to add that in.
Great. Thanks so much, Rob. And it's true. I mean, for Maureen and myself, whenever we have conversations with the steering committee, we're always learning new ways that the reports and the data were used. And Maureen did an evaluation to sort of poll the steering committee to see exactly how the report was used and in what sort of in what capacity. And that was a while ago, and we're now realizing that Maureen probably has to re-engage with the steering committee to find out some of the new ways that these reports have been used. So yeah, thanks so much for that, Rob. And I think maybe noticing that we don't have any questions in the chat box, maybe the one thing I'll just share at this point is how much work it's taking us in terms of the upcoming analyses. So as mentioned, we are working on 3 analyses chronic conditions, mental health and addictions, and injuries. And I want to just sort of give special credit to, as I mentioned, we have the other 2 members here joining us today, Beth and Yantao. And with Maureen and myself, the 4 of us, we will take a look at some of the preliminary findings from the chronic conditions analysis in particular. And we're realizing the importance of that context to the data. We are mindful that there is context to the data, and we're asking a lot of really deep questions about what it is that we're seeing. And we're hoping that when we do have that co-interpretation session, the steering committee and the people who will be a part of that gathering will also be able to fill in some of those gaps in terms of context, meaning like access to care, and you know, Paul mentioned about having the inability to have dialysis in a community because of the lack of clean water, which means then someone has to leave their community and go to an urban center to access that care. So these are some of the context pieces that we're realizing. As Maureen mentioned earlier in the presentation, it is just one piece of the puzzle, and we're doing our best to provide that piece, so then that way communities and regions can advocate for themselves. So noticing that we don't have any questions in the chat box, which is totally fine. Maybe what we'll do then is we'll end the presentation a little bit early. Maureen did have the slide up with our contact information, so I hope you had a chance to jot that down. As mentioned, the recording of the presentation will be made available on our YouTube page. And if you do have any questions, feel free to reach out through the links that were shared before. And